Good morning. Today we're going to discuss, basically analyze the ATP3 guidelines for hyperlipidemia, and we're going to discuss as well the 2013 guideline, which includes the age as well as diabetes and CKD. ATP3 guidelines refers to that is very important to determine lipoprotein level and your goal will be LDL for the treatment of hyperlipidemia. If you remember, we have different types of lipoproteins. We have the very low density lipoprotein, the low density lipoprotein, as well as the high density lipoprotein, which is the good cholesterol, and LDL, the bad cholesterol. This LDL cholesterol must be less than 100, and that's optimal for the ATP3 guidelines, even lower to less than 70 when there's a presence of stroke. But for all the patients that have CVD or cardiovascular diseases or cardiovascular disease equivalent, such as angina, MI, patients that have carotid artery stenosis symptomatic, peripheral vascular disease, etc., these patients must be less than 100 and less than 70 will be optimal. Total cholesterol, the desirable level for the guideline is less than 200, and HDL must be for female more than 50 and for males more than 40. It's considered to be very low when you have less than 40, and optimal for the guideline will be even more than 60 or equal. The second step for the guideline is to identify the presence of CHD or coronary heart disease or any type of risk equivalent. And this again will be any clinical cardiovascular heart disease such as angina, MI, if you have had a stent placement, if you had a CABG. Any symptomatic carotid artery disease, this does not include only the patients that have, for example, more than 70% carotid artery stenosis, but if you have had any symptomatic such as presyncope or syncope episode or any stroke related to carotid artery stenosis. Peripheral artery disease, this is the patient that has a thromboembolic event in the lower legs and is complaining of claudication, or have had, due to the peripheral artery disease, any type of arterial ulcers related. Abdominal aortic aneurysm as well is included in the CHD or CAD equivalent. The third step is to determine the major risk factors other than LDL, which is your goal. And this you must remember that includes cigarette smoking, hypertension, which is greater or equal to 140/90. That basically coincides with the new guideline if you are less than 65 years old or if you have or not diabetes or CKD, or if you're on antihypertensive medication. If you have a low HDL value, which is very low, less than 40 milligrams per deciliter, if you have a family history of premature death of CHD, which is the first degree relative less than 55 years old, or a female less than 65 years old. And the age as well. Don't forget the age. Men more than 45 years old or women more than 55. So if you have 0 to 1 risk factor, you're going to have a certain approach for treatment of hyperlipidemia. And if you have 2 or more risk factors, you would have a different approach. If you do have an HDL cholesterol more than 60, that counts as a negative risk factor, and therefore removes one of the risk factors from the total count. In other words, if you have 2 risk factors, for example, you're hypertensive more than 140/90 and you also smoke, having a total HDL more than 60 or equal to it, it would discount the risk factors to 1. So instead of counting 2 or more, this particular patient having more than 60 milligrams per deciliter would have 1 instead. This basically says that if you have 2 or more risk factors, and even more if in those risk factors include a patient having CHD or CHD equivalent, the mortality is greater than the others in the total population. So the guideline says that the first approach is to determine that the goal therapy will be the low density lipoprotein value. Then you need to establish therapeutic lifestyle changes for all the patients and then determine the level of drug consideration based on either CHD equivalent or the amount of risk factors. Now, let's interpret this box. Basically, your LDL is the goal. It doesn't really matter for the guideline if your cholesterol is greater than 200 or if your triglycerides are more than 150. All the time, your LDL would be your goal therapy unless your triglycerides are greater than 500. That's the only time that your goal shifts from LDL to triglycerides because of a high degree of mortality from pancreatitis ARDS and major inflammatory response. Okay, so let's discuss the LDL value. If you have CHD or CHD risk equivalents that we already discussed, if we go back, remember, if you have any clinical CHD, MI, angina, cabbage, if you have had a stent placement, etc., anything related to the heart, cardiomyopathies, end stage, CHF, more than 2 or 3, more than 2 in the New York classification, etc. If you have carotid artery stenosis symptomatic, if you have PAD or abdominal aortic aneurysm, then your goal, your LDL must be less than 100. Even less than 70 will be optimal, and it has to be less than 70, so it's a must when the patient has a stroke. If you do not have your LDL at less than 100, on the contrary, it's more than 100 but less than 130, then the patient must be on lifestyle modifications. Now, if you come back to me and your LDL level is more than 130, then you should start drug therapy. And the first choice will be statins or HMG coacetyl reductase inhibitors. So, if you have 2 or more risk factors, again, coming back here, cigarette smoking, hypertension more than 140/90, or an antihypertensive medication, you have a low HDL, you have a family history of CAD, or death prematurely, if you are men more than 45 or women more than 55, then if you have 2 or more risk factors, your LDL goal must be less than 130. Optimal less than 100, even more if you have a stroke. If you have the LDL more than 130, remember your goal is less than 130, but if it's more than 130, you must start lifestyle modifications. If you come back to me as a follow-up and you remain 4 to 6 weeks after more than 130 and even more than 160 or equal, then you must consider drug therapy, and statin will be your first line. On the contrary, if you have 0 to 1 risk factor, your LDL goal must be less than 160. If you're not less than 160, on the contrary, you're more than 160, you must start lifestyle modification. And if you come back to me and the level remains the same, and even more if it's greater or equal to 190, then drug therapy should be started. And again, the first line of treatment is statins. Again, if you noticed, there is a change by 30. By 30 as a goal and by 30 for therapy. So again, LDL goal, CHT, CHG equivalent less than 130. For 2 or more risk factors, less than 130. For 0 to 1 risk factor, less than 160. So 100, 130, 160. And for the therapy, 130, 160, 190. Now, what is the lifestyle modification? Again, reduced intake of saturated fat. Consider the introducing fiber, such as the oatmeals and high fiber diet, or plants that contain sterols, weight management, exercise. Now, which type of medication is the first line of therapy? We already said that we're the HMG, coacetyl reductase inhibitors, or statins. Why? I want you to again notice that the percentage of reduction of your goal. Let's compare first the LDL across all the medications, and then we'll do the rest for the HDL and triglycerides. And this is the explanation why statins are the first line treatment for reducing LDL, which is your goal. If you look at the statins reduces LDL to 55%. Compared to bile sequestrants, 30%, compared to nicotinic acid or niacin, which is 25%, compared to fibrinic acid, which is 20%. So because statins reduced LDL to 55%, this is the reason why statins are the first line of therapy for all the patients to reduce LDL, which is your goal, unless contraindicated. And what are the contraindications? Well, if you have any liver failure, or if the patient complains of signs and symptoms of myopathy, such as myalgias, muscle weakness, etc. Or if when the patient complains of these signs and symptoms, and if you measure the CK and the CK level, and those are elevated. In addition to that, contraindications will be patients that have, again, liver failure or elevated liver enzymes. And of course, relative contraindication would be putting the patient on statin, knowing that this patient is already taking a medication that might increase the risk of liver failure. Such as, for example, if you put the patient on any type of antifungal medication that would increase the liver enzymes. If, for example, you take cyclosporine or any macrolide antibiotic or any medication that will be an inhibitor of the cytochrome P450, including antifungal medications. So have in mind that concomitant use of drugs that would increase liver enzymes will be a relative contraindicated, but not an absolute. Absolute contraindication would be, again, any active or chronic liver disease, any elevation of liver enzymes. You would never ever start statins when the patients have that. And in addition, if the patient complains of myopathy, and even more if the CK or CPK levels are elevated, you must discontinue the medication. Examples of statins are lovastatin, pravastatin, simvastatin, which you would see that simvastatin is the protocol used for the new guideline. Now, let's compare HDL values. Which is the best medication that increases HDL? Which, remember, optimal must be more than 60 or equal. If you look, statins are not good for that because only increases it to 15%. Bile sequestrants only 5%. Nicotinic acid is very good at 35%. And also fibrinic acid, which is 20%. So if you would like to increase even further HDL levels, even though it's not your goal, the best medication would be nicotinic acid and fibrinic acid. Now let's discuss triglycerides. If you look at the percentage of decrease of triglycerides, statins only reduce triglycerides to 30%, compared to nothing on bile acid sequestrants, compared to 50%, very good, for nicotinic acid, and 50% for fibric acid. So Again, for triglycerides reduction, you would be choosing nicotinic acid and fibrinic acid. Third line of treatment will be bile acid sequestrants. Okay. Now let's discuss a little bit of the second line of treatment, the contraindications. We said first line of treatment will be statins unless contraindicated. Second line of treatment will be nicotinic acid and fibrinic acid unless contraindicated. Why? Because triglycerides are reduced best by nicotinic acid and fibric acid, and HDL is increased the best by nicotinic acid first and fibric acid second. Now, again, absolute contraindications, the same as statins, will be any liver disease. In addition, nicotinic acid will increase the incidence or production of uric acid, so severe gout will be another contraindication. Okay? Absolute contraindications for fibric acid will be the same, hepatic disease. In addition to that will be severe renal disease. So if I were you, for absolute contraindications to best memorize for all the drugs, active or chronic liver disease, so anytime there is liver enzymes elevated, is a contraindication absolute for all the drugs. In addition, renal problems, myopathies, as well as severe gout for nicotinic acid. And the problems with nicotinic acid is because of release of prostaglandin. And release of prostaglandin, remember, is a potent vasodilator that impedes autoregulation of the kidney and increases uric acid retention. Now, when that happens, patients cannot be started on. When the patient has active or chronic liver disease, anytime there is liver enzymes elevated, you cannot start statin, you cannot start second-line nicotinic acid or fibrinic acid. What you would do is either put the patient on lifestyle modifications, or you could start bile acid sequestrants or resins. Okay. Additional risk factors that are not included in the prior block is having, of course, an elevated BMI, elevated triglycerides, and we discussed already blood pressure, and also being a diabetic or having metabolic syndrome. Okay, so basically, what do you have to do for to reduce risk factors in addition to the one already discussed? Try to intensify weight management and increase physical activity, treat hypertension. You could also use aspirin to promote and actually decrease the chance of prothrombotic state and platelet aggregation, and also treat elevated triglycerides, which again is not your first goal. Your first goal is LDL. Unless triglycerides are greater than 500, then you switch your goal. Now, to discuss a little bit about triglycerides, remember that triglyceride must be less than 150, okay? It is a high risk of mortality when the triglycerides are greater or equal than 500. So, if you basically try to interpret this, when the triglycerides are greater than 150, it doesn't really matter. Your goal remains LDL. You continue doing the same thing, okay? Weight management, lifestyle modifications, and continue your statins unless contraindicated. You basically continue the same goal as we discussed above. CAD equivalents, your goal is less than 100. If you're not less than 100, then you must start lifestyle modification. And on the contrary, if it's more than 130, then you start medication. If you have two or more risk factors, less than 130, optimal less than 100, even more if you have a stroke. If you're not less than 130, then you start a lifestyle modification. And even if you come back to me with the same value or even higher, more than 160, then you start medication. If you're 0 to 1 risk factor and your LDL value must be less than 160. If you're not, then lifestyle modification. If you come back to me higher to 190, then you start medication. Now, what do you do if your triglycerides are 200 to 499 but less than 500? Your LDL continues to be the goal. It doesn't matter. It doesn't change. Okay, what you could do is intensify the therapy of statins or add nicotinic acid or fibrinic acid to even further reduce your LDL and even your very low density lipoprotein. Now, if your triglycerides on the contrary are more than 500, then your goal shift from LDL to triglyceride. You must first lower triglycerides to prevent pancreatitis because this will entail a very high mortality. So again, weight management, lifestyle modifications, but instead of starting statins, you would start fibrinic acid or nicotinic acid. All right, then once your triglycerides are less than 500, then you switch to your LDL lowering therapy. Okay, to be able to increase HDL, even though your HDL is very low, concentrate on your LDL goal first, do lifestyle modifications, and do continue the same even if your triglycerides are high but less than 500. This is basically to estimate the risk for men and women based on the Framingham point score. Is basically to determine if you have a high mortality of more than 20 or if it's more than 10. Okay, so now since we already discussed the ATP3 guidelines, let's talk a little bit about the updates of 2013 guideline for the treatment of blood cholesterol to be able to reduce the cardiovascular risk in adults. This guideline does not approach the goal for the LDL, not even discusses the HDL goal or triglycerides. Basically, what it does is to concentrate on patients by age and population that has any type of coronary artery disease. So basically for this guideline, when I refer to atherosclerotic cardiovascular disease, that includes coronary heart disease, includes stroke, include peripheral artery disease, and even presumed atherosclerotic origin. Remember that the first etiology for CHD or coronary heart disease is atherosclerosis. So we basically presume that all these risk factors were provoked by atherosclerosis. So let's discuss a little bit, and I basically highlighted the most important part of this guideline. Is the guideline is basically intended to address age, and there are different type of population that we'll discuss. Is basically more or equal than 21 years old, because these patients, if they do have any type of CAD or CAD equivalent risk, because, for example, they even had a viral disease that produced myocarditis, or the patient just was born with a cardiovascular congenital heart disease. Okay, so basically it's by age, and also to try to treat the cholesterol to the target, uh, to lower it at best, but it never basically approaches the numbers of LDL value. Okay, the guideline also talks about using either increasing the medication uh, or using a fixed dose of medication. And at the end, we'll realize that the guideline favors to use either a low to moderate intensity regimen, such as atorvastatin 40 milligrams, or using 80 milligrams high intensity drug use. As I said, this guideline was never intended to be a comprehensive approach, and it does not substitute the ATP3 guideline. So, basically is doing an overview. Remember that the guideline is basically targeting the atherosclerotic coronary vascular disease events and discussing the therapies of treatment, either primary or secondary populations, based on the dosage of statins. And they took atorvastatin as a prototype. Okay. Now, they also include a New York classification of heart failure, 2 to 4, that were receiving hemodialysis. They also include diabetes. Okay. They were unable to find any supporting evidence that titrating cholesterol lowering drug therapy would achieve any target LDL or non-HDL level. So basically what they recommend is to use a fixed dose, either atorvastatin 40 milligrams or atorvastatin 80 milligrams, either if it's a moderate intensity therapy or high intensity therapy. There is also no evidence that the addition of niacin or even fibrinic acid was of benefit. Now, they continue to introduce and basically favor, they emphasize lifestyle modification. The patient must adhere to a heart healthy diet, a regular exercise habit, avoidance of tobacco products. In addition, try to maintain healthy weight by exercising. Again, the guideline says that basically is try to approach blood cholesterol panel by risk factors. Okay, so are you in a primary or secondary group? Are you in the CAD or CAD equivalent group? Are you a diabetic, or are you that patient that is in CKD in hemodialysis? Continue to approach lifestyle modifications. Now, the guideline, we're going to continue on, but the guideline basically abbreviates that. Are you a patient that has clinical atherosclerotic cardiovascular disease that we already discussed? We have an MI, angina, CABG. This patient that has CHF with 2 to 4 New York classification, you had a stent placement, you have an advanced cardiomyopathy, etc. Okay, if you're less than 75, less or equal than 75 years old, and there's no safety concern, meaning that you don't have renal failure, you don't have liver failure, you don't have myopathies, which are the major contraindications for statins, then you should start high intensity therapy. But on the contrary, if you're more than 75 years old, or you have any safety concern, not including, of course, liver failure. Why? Because remember that majority of patients that have 75 years old, they already have decreased nephron population. So even though they're not on renal failure, there is a major concern because of the declining system function or organ function, that it makes sense that you would start this population in a moderate intensity statin. And when I say moderate intensity statins, remember that this research study took into consideration atorvastatin 40 milligrams, and high intensity will be 80 milligrams. Okay, so any patient that is less or equal than 75 years old and there is no safety concern, high intensity statin. More than 75 years old, moderate intensity statins. Now, if you have diabetes, then you must start the patient on moderate intensity statin. Why? Because the guideline also proved, or this research study also proved, that statins will increase blood glucose levels to patients that are already diabetic, or there is a high consideration that statins will provoke for the first time a diagnosis or the appearance of type 2 diabetes on patients that have never been diabetic. So therefore, if you're already a diabetic, you should not start high intensity statin. On the contrary, you should start atorvastatin 40 milligrams. Okay? So diabetics, moderate intensity statins. Re-emphasize lifestyle modifications all the time. Okay? In addition to that, you have to assess adherence before increasing the medication. Um, you have to measure fasting lipid panels. You do not have to measure routinely CK or CPK levels unless the patient complains of signs and symptoms of um, rhabdomyolysis or any type of myopathy. You must screen the patient according to diabetic guidelines for diabetes. Again, either a random blood glucose level or 2 hours postprandial glucose or fasting blood glucose levels, including hemoglobin A1C. Okay. Now, you anticipate therapeutic response to approximately more than 50% reduction of LDL with high intensity statins and 30% to 50% to moderate intensity statins. That's what they found in this guideline, that by using high intensity statins, the LDL were able to be decreased more or equal than 50% compared to the prior ATP3 guideline by titrating up or down. So using a fixed dose of 80 milligrams of atorvastatin, the LDL were able to be reduced more than 50% compared to 30 to 50% when atorvastatin 40 milligrams or moderate intensity statins were used. This is very important for your examination. In addition to that, remember the LDL, even though it was not approached, continue using your LDL as a goal. And if you have any type of CAD or CAD equivalent, you must be less than 100, even less than 70 is optimal using a high intensity statins. Reinforce adherence to lifestyle modifications, evaluate any secondary causes of hyperlipidemia, increase the statins, okay, when the patients are maximally tolerating the moderate in selected high-risk individuals. But again, remember that this guideline favors the fixed dose instead of titrating up or down. Okay, so again, use a statin for the prevention of any type of CAD or CAD equivalent in high-risk primary or secondary prevention, even including heart failure, but without grade 2 to 4 in the classification, and those patients that were not receiving hemodialysis. Again, moderate intensity statins reduces the level of LDL to 30 to 50% and high intensity statins more than 50%. Okay, remember that statins is your first line of therapy. These are the benefits that the statins will give you. Improve the clinical CAD or CAD equivalent, improve the levels of LDL. Okay, for primary prevention, those patients that have diabetes, 40 to 75 years of age. Okay, even individuals without diabetic, but if they have more than 10 years risk of dying from coronary heart disease. Another group of population is this group of patients that have 10 years as well, but less than 5%, but they include also patients that have less than 40, for example, they're 21 years old. What is clinical atherosclerotic cardiovascular disease? Acute coronary syndrome, history of MI, stable or unstable angina, any type of revascularization, any stroke, any TIA, any PAD. For primary prevention, remember your goal, okay? In addition to that, having 10 years risk of atherosclerotic cardiovascular disease is defined as non-fatal MI, CHD death, or non-fatal or fatal stroke. Now, the risk-based decision based on LDL was completely unclear in this research study. Titration is not in favor for this research study. Basically, a fixed drug is what is best. Okay, so this is basically the algorithm of what we already discussed. If you're more than 21 years old and you're a candidate for statin because you had a clinical CAD, you had a congenital heart disease, then you should start statins. If you also have a clinical CAD and you're less than 75 years old, then you should start high intensity statins. Again, 80 milligrams of atorvastatin. If you're more than 75 years old, okay, then you should start moderate intensity statin, which is what? 40 milligrams of atorvastatin. If your LDL is more than 190, remember this is at the end of your ATP3 algorithm. This is when you have 0 to 1 risk factor, okay, and you're more than 190 milligrams per deciliter, you should start high intensity statin. If you're diabetic, because statins will increase the levels of glucose, you should always start a moderate statin unless you have a high risk of mortality, more than 10%. So for primary prevention, remember lifestyle modifications, okay? If you are less than 5% death, or if you are between less than 40 years of age or more than 75 years of age, then lifestyle modification with a moderate intensity statin if it's needed. On the contrary, if your high risk of death is high, okay, then besides emphasizing lifestyle modification, you should start moderate intensity statin. And you know already what the lifestyle modifications are. This is basically the summary of this guideline. Remember that high intensity statin, okay, is atorvastatin 80 milligram, and moderate intensity statin would be 40 milligrams. Okay. So again, if you come back here, is atorvastatin, high intensity. The guideline says 40 to 80, but if you continue reading, they favor 80. So 40 to 80, and moderate intensity statin is 40 milligrams, but you could start, if you are not sure, then to 20 milligrams and even 10. But again, titrating up or down is not in favor of the guideline. The guideline says to start fixed dose of atorvastatin 40 milligrams when you're in moderate intensity and 80 milligrams when you're in high intensity. Okay, and where do you start high intensity? It's even highlighted for you. High intensity statins should be initiated for adult less than 75 years old, less or equal, with clinical signs and symptoms of CAD. Okay, that's atorvastatin 80 milligrams. Now, unless contraindicated, of course. And moderate intensity statins for more than 75 years of age. Okay, here's your definition again for clinical CAD, so you don't forget. Okay, if the patient is clinical CAD and is not currently on statin, what do you do? Well, I'm going to initiate, before starting the statin, I'm going to do a fast lipid panel. I'm going to do liver enzymes. I'm going to do CK if indicated, because remember, it's not a routine to do it unless the patient complains of signs of myalgias or myopathies. Consider secondary causes. Evaluate if the patient has triglycerides greater than 500, because if so, then statins should not be used. Instead, niacinamide acid. Check your LDL levels to see if it's greater than 190 or not. Look for secondary causes. Okay? If the patient is less or equal to 75 years old and there is no contraindication, start high intensity statin. If the patient, on the contrary, is more than 75 years of age, you have considered already drug and drug interaction or any type of contraindication or history of intolerance of statin. If not, then start moderate intensity statin. So for here, 80 milligrams, for this group, 40 milligrams, and continue monitoring statins, your fasting lipid panel, your liver enzymes, and renal as well. Remember that it's not a routine to do CK or CPK level. All right, unless the patient complains of signs and symptoms of myopathy. All right. For patients that are greater or equal than 21 years of age and the LDL is more or equal than 190, then consider high lifestyle modifications and high intensity statins. What else do you do? Look for secondary causes. Is the patient taking saturated fat? If the patient has anorexia nervosa, is the patient in any type of diuretic? Because remember, thiazide diuretics will increase the lipids. Any cyclosporin, any glucocorticoid, amiodarone, any biliary obstruction or nephrotic syndrome, any hypo or hyperthyroidism, obesity, pregnancy, etc. Those you have to rule out secondary causes of hyperlipidemia. Again, there's no clinical CAD. You have not started the patient on statins. If you consider at any time starting the patient on statin, do this blood test first. Okay? Consider the patient is a high risk or moderate risk. If the patient is diabetic and is between age of 40 to 75 years of age and the LDL is greater than 190, then what you should do, you come here, you have to start the patient on moderate intensity statin. Look for any drug and drug interaction. Look for any considerations of contraindications of statins. Re-emphasize lifestyle modification. This patient, remember, you should start the patient on moderate intensity statins. If the patient is not a diabetic, then you could do high intensity statin based on the risk factor of mortality. Remember that high intensity reduces the LDL to 50% or more. In addition, you should do family screening. Okay, because remember there is a syndrome that is called familial hyperlipidemia that must be considered. Ask the patient if this is happening on their family. Okay, look for patients that have triglycerides more than 500, because now your goals shift from LDL to triglycerides, and what could be the possible cause. Remember that it could be excessive alcohol intake or uncontrolled diabetes or albuminuria in nephrotic syndrome. Remember that if the patient has diabetes, again, they must be on moderate intensity statin because increases the blood glucose levels and even put the patient at risk for the first time diagnosis of type 2 hyperlipidemia. All right? Unless the patient is diabetic, but it has more than 7.5 risk of death in the 10 years. Then in that case, you should start high intensity. Otherwise, for all the patients with diabetes, if they have less than 7.5 risk of mortality, you should start moderate intensity. Otherwise, high intensity. Okay? Always look at risk reduction benefit, drug and drug interactions. Don't forget that. We already discussed this in the algorithm. If you're 40 to 75 years old of age and you're not already a candidate for statin, okay, or you're diabetic and your LDL is greater than 90, then you should do a blood panel screening before starting statin. And this is what I just said. Conservative should be estimated in patients who are diabetic because the excess of statins could produce a new onset of diabetes and even hemorrhagic stroke. I know that statins prevent the patients from stroke, ischemic, but it could produce hemorrhagic stroke. Additional factors that must be considered, okay, factors that can contribute to CAD risk include the LDL greater than 160, any genetic hyperlipidemia, any family history of premature death that is already discussed in the ATP3 guideline, patients that have C-reactive protein more than 2, any coronary artery calcium level more than 300, and Agatston unit score more than 75 percentile. This is high risk for death. Now, the safety considerations, you know them already from ATP3 guideline, is impaired renal or hepatic function. Those are contraindications. Any history of prior intolerance to statin or any myopathy, any concomitant use of drug that could affect the liver metabolism and first pass effect, any history of hemorrhagic stroke, or age more than 75 years of age, you must decrease the dose in this type of population in more than 75 years of age because already they have a decline function of kidney and liver. But for the rest, it's absolute contraindication. You have impaired renal or impaired hepatic function, or if you're intolerant to statins, or if you have had myopathies, or any history of hemorrhagic stroke, you should not start statin. Okay? But if your age is greater than 75 years of age and you have no contraindication, then start moderate intensity statins. Again, this is a question of a test. This guideline recommends against routine measurement of CK or CPK unless the patient complains of myopathy. And that is basically suspected when the patient complains of muscle weakness, fatigue, aching, pain, tenderness, cramps, or stiffness. This guideline also recommends to do a baseline measurement of liver panel, ALT and AST. So measure the function of hepatic panel. Patients that are suspected for hepatotoxicity are the ones that are complaining of unusual fatigue or weakness, any loss of appetite, abdominal pain, dark color urine, or yellowish of the skin or sclera, which is icteria. This decrease in the statin dose may be considered when 2 consecutive values of LDL are less than 40, but never discontinue them. Again, lifestyle modifications should be encouraged all the time. They should be evaluated for diabetes before starting the treatment. They should be encouraged again to healthy diet and physical activity and stop tobacco abuse. Statins should never be started in pregnant women because they're category X. Again, use caution for patients that have greater than 75 years of age and they're taking any concomitant medication that could alter the liver function and renal function. Any patients that are undergoing transplantation or receiving treatment for HIV will counteract with the statins. Now, what do you have to monitor again? Initial fasting lipid panel. Then you should do lipid panel subsequently 4 to 12 weeks after initiation of statins. Then thereafter, if everything's okay, you could do follow-up every 3 to 12 months. As a summary, what are the indicators for therapeutic response? Well, if you are in high intensity statin, you should expect LDL reduction of more than 50% or equal. If you're moderate intensity statin, you should expect LDL reduction to 30% or 50%. And remember, adherence, you have to always monitor adherence. And what is this reduction again? If you come back here, you should do it every 4 to 6 weeks, and then every 3 to 12 months thereafter. In some patients, you could do it 4 to 12 weeks, but it's 4 to 6 weeks follow-up. So you should expect 50% reduction in high intensity and 30 to 50 in moderate intensity. Okay, so basically conclusion, and this is more or less what you have to know. When do you start statin, and or the groups that will benefit? Any patient that has clinical CAD or CAD equivalent, any individual that has LDL greater than 190, any individual 40 to 75 years old with diabetes and LDL 70 to 189 without CAD equivalents, or any individual without clinical CAD or diabetes who are 40 to 75 years old of age and has greater than 7.5 reduction mortality. Again, if you are in that group, moderate intensity statin. If you are as well more than 21 years of age, if you are less than 75 years of age and you do have CAD or CAD equivalent, then high intensity statins. And this is the end of the guideline presentation.